Hi, I'm Dr. Bill Gradishar, professor of medicine at Northwestern University in Chicago.
Hi, I'm Dr. Tarah Ballinger. I'm an associate professor of medicine at the Indiana University School of Medicine.
And I'm Dr. Megan Kruse. I'm an assistant professor at Cleveland Clinic.
And we're delighted to be joining you from San Antonio, where we've been experiencing the onslaught of new data that we're hopeful will impact on patient outcome as we think about some of the new therapies we'll be talking about. And to start us out today, I'm going to ask Dr. Kruse if you could sort of put in perspective, since we're going to sort of focus on HER2 subset of breast cancer, if you could sort of put into perspective for us what the Cleopatra regimen is briefly. I think most people know, but what the impact of that treatment has been basically for the last decade.
Yeah, I mean, I think Cleopatra is transformative. We've been very lucky that for the better part of a decade, we've been able to use the regimen of a taxane with trastuzumab and pertuzumab for first-line care of HER2-positive metastatic breast cancer patients. And part of the reason that we love this data is we saw an incredible overall survival benefit of over a year, close to 16 months, that was sustained over long-term follow-up. And when you look at these curves, you see that many patients are still alive up to 8 years out from the start of the trial. And I think we've all had the experience that patients who respond to that regimen, you always have those that have long-term responses. And so it's a regimen that we feel confident in. It's a regimen that patients feel good on. And it's really changed the natural history of this disease where, becoming more of a chronic illness for many of our patients, which I don't know that we thought was possible. Yep. Over a decade ago.
So Dr. Ballinger, let me ask you, because we're going to get into some of the nuances of this trial compared to some of the newer data. And, one of the things that's unique about Cleopatra is you stop the chemotherapy. Yep. And I just wonder if you could comment on the mechanics of the study in a sense.
Yeah, I mean, I wasn't practicing at the time, but I think at the time it was fine. I just wanted to drive that home, but at the time, I think that was a very novel idea to do that kind of induction therapy followed by maintenance. So the fact that patients can do the more toxic chemotherapy part up front and then remain on maintenance trastuzumab, pertuzumab that's much better tolerated and, like you said, sustain a response. And maybe some patients are even cured. So I like that induction sort of mechanism. And I think as we talk about newer data, trying to think about how that all fits together.
So we have, a lot of experience with Cleopatra. We have these patients who may be cured, but certainly are out long-term on H&P, doing well. And, I think it probably is still the minority. I mean, nobody's, out 5 and 10 years. There are many folks. But that really highlights the point that this isn't the final answer to treating patients with HER2-positive metastatic disease. So can you comment on what you think as the unmet need going forward?
Yeah. As happy as we are with this regimen, it's not sustaining our patients lifelong. They don't have normal life expectancies, most of them. So I think I worry the most about patients who, especially in the modern era, have so much therapy coming into their metastatic diagnosis, right? Over the time that we've been using Cleopatra, we're using many more drugs in the neoadjuvant adjuvant space. And so I always worry that the effects that we saw in Cleopatra may not hold true for the patients we treat in the modern way today, with a lot more neoadjuvant therapy, pertuzumab-containing therapy, T-DM1 adjuvant therapy. And then we've all had that experience where these patients have their CNS involvement. And I worry that for those patients, while they still get meaningful responses to the Cleopatra regimen, that their outcomes may not be the same in the long term as some of these exceptional responders we originally saw in Cleopatra. So, I think there are still unmet needs, and separating out who are those patients that maybe need more than what we have available up until the very recent past is important.
Yeah, I think if we could figure out who, I think there is, thinking about the possibility that we could cure stage 4 disease is very exciting. So for me, the unmet need is how do we select out the patients for whom that might be possible? And then how do we figure out if those are the people that need more upfront and they need everything upfront, or are they not? And how do we tease all that out and select which patients are appropriate for that. So I think it's exciting that we may get there, but I think that that's where I'd like to see us going next.
But even based on Cleopatra, when you're thinking about that regimen, which we have a huge experience with, and then we're going to start talking about some of the newer regimens, when you're thinking about, the clinical endpoints we look at in a trial, whether it's response rate, progression-free survival, overall survival, toxicity profile, do one of those elements trump the others in your mind?
I don't know if one trumps the others in my mind, but I think for if we're talking about frontline metastatic disease, I think overall survival is the big one because that's what we're trying to do. We're trying to keep people living longer and living better. It's hard to tease that out in a lot of these trials, but I think that's an important endpoint. Complete response rate and the duration of that, like you were mentioning, I think is really important. And one thing I think we're still missing from some of the newer trials is the quality of life data. Time to deterioration and quality of life, that kind of endpoint, I think, in the metastatic population is really important.
Does that capture pretty much through your thinking as well?
Yeah, absolutely. I think being able to adjust these regimens over time for our patients and knowing what that does to the efficacy is really important because inevitably you have patients that are responding really well, but there's just lifestyle factors that come into play, right? They can't make it to the infusion center or they're just tired of getting treatment. And like, how much flexibility do we have here? I think that's another unmet need that we didn't mention before, but it comes into our practices every day.
Yep.
So with that as our foundational, where we've been, where we are in a sense, antibody drug conjugates have been all the rage. We've had TDM1 for several years now, but the one that appears to be even more potent and active is trastuzumab deruxtecan. So would you mind just sort of giving us a brief 10,000-foot view of that trial?
Yeah, so we know from the suite of DESTINY-Breast trials, we know that trastuzumab deruxtecan outperformed TDM1 in the second-line setting. So then we've recently heard at ASCO earlier this year, and then I think was published in the New England Journal of Medicine, the results of DESTINY-Breast09. That trial had 3 arms, the traditional Cleopatra regimen arm, T-DXd alone, and T-DXd plus pertuzumab. So what we've heard so far is the T-DXd plus pertuzumab versus the traditional THP arm. And on the T-DXd plus pertuzumab arm, that's the therapy that they received throughout the whole duration of the trial. And we saw a significant improvement in progression-free survival for the patients receiving T-DXd, which I think is what probably most of us expected. And now the question is, how are we going to implement that?
So when you think about that data, which is pretty compelling with a very enhanced time until the disease progresses, are there any patients that you wouldn't give it to?
I'm conflicted. I think I want to give my patients the best therapy up front because I would not at all be surprised if the large improvement we see in progression-free survival translates into an overall survival advantage. And I think we feel that with the use of T-DXd in other settings. So there's this great enthusiasm to do it. I think that you hit the nail on the head earlier about the induction phase, where I'm just a little bit hesitant for these patients who may get great outcomes with this tough upfront induction phase, including taxane, but then a much nicer maintenance phase that may be consistent with their quality of life and day-to-day responsibilities, giving them true cytotoxic therapies indefinitely. And so when I think about which patients am I a little reluctant to do that in, sometimes it comes down just to disease burden. For those patients that might be bone-only lymph node involvement, the hormone-positive patients where we may have some other options to add that we'll talk about. And then also the performance status piece. If there's somebody who I really worry that I could make their quality of life much worse with this drug, am I going to use it now versus save it till later? So it's really a personalized decision for each patient that comes in the door. But I think we have to be honest about where the data is now and where we hope for it to be. And just kind of see where that lands for them.
Yeah, we've always had this idea that, you're not supposed to save the good drugs for later. Right. We tend to use them up front. So do you sort of share the sentiment that you would likely use it more often than not in first-line therapy?
Yeah, I mean, I think in agreement, I'm a little bit conflicted, and I think it will be a patient-by-patient choice because I think I still don't fully know, do you need to get it up front or do you just need to get it at all? And I think making that decision up front will depend on the factors that Dr. Kruse already mentioned. Also, I think I'll think about de novo versus recurrent disease. I'll be much more likely to use the DB09 regimen in people with recurrent disease who received trastuzumab and pertuzumab in the curative setting. So I think that will play in my decision as well. But I think we'll also have to talk to patients about the two trials and kind of see what they prefer.
And then they'll say, doctor, what do you think I should do?
What would you do if you were me?
Exactly.
Yes.
Yeah, if this was your wife.
I know.
That's always the inevitable question.
Yes. We're leaving out the one piece that makes us all a little nervous, which is the toxicity element of interstitial lung disease.
Excellent transition point. So you mentioned it, so you can take it on.
I know. I probably shouldn't have wanted to take that one on, but I think, if we didn't have that toxicity there, where we're hoping these patients have long-term survival, like, would it weigh on us so heavily to be using cytotoxic therapy right now? I'm not sure that it would. I think the lack of a maintenance phase without cytotoxic and having this potentially long-lasting and fatal toxicity, even though it's rare, right? We know that there were only a couple of deaths due to ILD pneumonitis in this trial. We don't know how to predict who those patients are. If we knew who needed this benefit, who was more at risk of ILD, I think that would make us all a little bit more comfortable, because we're still in that, don't harm these patients who could live for many, many years.
So when the drug was first being developed, and it's probably still in some of the recommendations to be evaluating patients above and beyond querying them about side effects, scans every 6 to 8 weeks. So can you envision doing that long term in somebody who's on it for?
Yeah, that's one thing I've thought about the trial, because definitely in my patients who are on the Cleopatra regimen and have been on it for years, we're either scanning every 6 months, once a year, only in the presence of symptoms, depending on the patient. So the idea that we need to scan more rapidly to look for ILD, I'll probably back off a little bit if they've been doing well for a while, and encourage them to come to us very early, make sure that the patients fully understand how important it is to come to us early with any cough or other respiratory symptom. But I think that does just add to the burden of the regimen.
Yeah, and we do have these patients that get some shortness of breath or whatever, they're grade 1, I guess. Do you have any reservation about reintroducing trastuzumab deruxtecan?
No, with the grade 1 toxicities, respiratory toxicity, just radiographic changes of pneumonitis, I think we have actually a good amount of safety data right now where we feel comfortable with that. And in clinical practice, I think we've all done it. And it's always on your mind, because many of those patients are benefiting from therapy when you see that they have this radiographic change on the scans. And, all of us in the Midwest, we know that this viral season, it makes your life hard, because is that cough just that virus that's going around, or is it something more? And you would hate to stop active therapy if you really didn't have to. So for the grade 1s, I have no qualms about re-challenging. I always wonder a little bit about those patients who maybe are mildly symptomatic, and can we come back around to the drug? And of course, per the guidelines right now, we can't, right? As soon as a patient is symptomatic, we should withhold any more TDXD. But I think it's an area of concern that, we as a field will be thinking about in the future, especially if patients are on this for a very long time.
Yeah. Any different view on that?
No, I think I agree.
So let me have you comment then on any other of the side effects that have been associated with, again, we deal with nausea, vomiting, diarrhea, and all the other drugs we use. Is there anything else unique about TDXD that?
I mean, what I've seen in my practice is the nausea, but patients almost describe the nausea in a little bit of a different way. I have a lot of patients that just sort of feel a general malaise, I feel like, with the drug. And some patients tolerate it really well, but I have some patients that really struggle with it. And so, again, I worry about the idea of keeping those patients on that long term. I have found success with dose reductions usually help with that. Olanzapine usually helps with that. So I think there are ways to manage it and try to get ahead of it. But I would say that is the most common kind of chronic day-to-day issue with the drug.
And in my view, the one that we've all touched on that we, focus on is the ILD. Mm-hmm. The other things we're pretty accustomed to managing. So,
yeah.
All right. So let's move on. The way DB09 was set up, DESTINY-Breast09, is you just stayed on it. Mm-hmm. Just kept going. There have been other trials recently. You alluded to one of them, particularly in patients who are HER2 positive, ER positive, or they took a somewhat different approach, not with TDXD, but with the chemotherapy component. You want to comment on that?
Sure. So I think DB09 came at a very interesting time because we also had the results from PATINA that I think we are all very, very excited about, where patients who were already responding to their Cleopatra-style regimen, after they finished that induction period and they were hormone receptor positive, were then randomized to get palbociclib with endocrine therapy plus their HER2-targeted agents versus the HER2-targeted agents and endocrine therapy alone. And I mean, that trial was actually kind of a surprise hit for me. I mean, I expected that we would see benefit because I think we've known that CDK4/6 inhibitors in HER2-positive disease have had activity for a while, but I guess I didn't expect the magnitude to do so well. And not only did we see the control arm performing very, very well, but then the patients who got palbociclib had really an impressive improvement in their progression-free survival. And I think we're all very comfortable with palbociclib. We've kind of been looking for a new home for it. Yep. And so when you see that amount of activity with a drug that you're very comfortable with, it leaves you to say, okay, you know, this is something I would be very comfortable incorporating. But again, we don't have a clear maintenance phase for if we're trying to incorporate DB09 with PATINA. It's a little bit hard to know how to do that. I think we're all finding our way. We're all talking about, you know, is there the opportunity to have an induction phase with TDXD plus pertuzumab? We're not there quite yet. There's going to be some data that will lead us there with the Demether study, I hope. But we have some good maintenance data that we should think about with PATINA. And then at this meeting, we saw the data from HER2CLIMB-05, which is looking at use of tucatinib in that very similar maintenance setting. And here we're looking at hormone receptor positive and hormone receptor negative patients. And we saw a benefit in both subgroups, I think more compelling in the hormone receptor negative population perhaps. But certainly now we've got two agents with different mechanisms of action that we might want to use in this population. So a lot of data all at one time. And I think this is where sort of that clinical gestalt impression is where we're going to make a lot of decisions in the short term of like, what did the patient receive before for therapy? How much is their disease burden now? What's their performance status? How aggressive can we be? And we'll figure it out along the way.
So in your community, broadly speaking, not at the university, but broadly speaking, do you find people are adopting TDXD, not necessarily in this setting, but just more broadly?
Yeah, for sure. I mean, I definitely noticed when the drug first came on the scene that I was seeing a lot of second opinions in people who hadn't gotten it, but I think everyone's becoming a lot more comfortable with it. I think moving it up into the front line, I think we're going to once again see in the community a lot of questions about how to use it and more kind of referrals to the academic centers to tease that out. And then I think it will start to be more widely adopted in the same manner. And I think in my practice, I do think it's going to be difficult because like you said, I think Cleopatra and DB09, a lot of the patients didn't get endocrine therapy at all.
Right.
So it's hard to know what to do with those patients specifically. I think the DB09 regimen will be easier for me to implement in a HER2 positive, ER negative patient. Yeah. But in the ER positive, for me at least, that induction switching over to a maintenance that includes endocrine therapy feels like a better approach.
Yeah, I mean,
without data.
Yeah, right. I was going to say, you know, if we make the switch, we're really switching away from TDXD,
yeah.
Particularly if we're thinking about a CD4/6 inhibitor, because then you have two drugs that can cause hematologic toxicity on board. Have you had any issues with payers about getting TDXD in any setting to date?
I haven't. It's been pretty straightforward, and I haven't really broadly applied the DB09 data yet. But, you know, there have been a couple of patients that were very heavily pretreated in the early stage setting with early recurrences, and we were able to get TDXD for them. So, I think, and of course it's worked. So we have the confidence there.
Yeah.
So we talked a little bit about PATINA and a pretty striking PFS in that subset of patients. You mentioned HER2CLIMB-05. So could you think about that as an alternative to this approach, or are you thinking TDXD for 6 cycles, and then, I don't know, you're going to switch to, I don't know what, HB and tucatinib, or are you thinking about THB then? I mean, how are you thinking about that?
I honestly think it depends on the day. Every time I look at this data, I feel like I come out a little bit conflicted and have a different perspective. But I really feel like we're moving towards a situation in which we may approach, as you said, the hormone receptor negative separate than the hormone receptor positives. I actually feel like I'd be very comfortable sticking with Cleopatra and going straight into PATINA for my hormone receptor positive patients. And I kind of like that approach because I feel like then I will have TDXD a little later, and then I'll have tucatinib a little later. For the hormone receptor negative patients, it almost feels worth it to be as aggressive upfront because I just don't know what that biology is going to do. And I think to your point about using our best drugs first, to me, it feels like that's where I have to do it. But I don't think that's a hard and fast rule. I think there are going to be patients with, especially those with significant disease burden, where I want an almost assured response as quickly as possible. And for me, doing that would be TDXD plus pertuzumab up front. Then I think we play it by ear a little bit. I think I'd probably set to maybe maximum response for those patients where I commit to TDXD post pertuzumab up front. I don't know that I'd say, 6-ish cycles like we do with Cleopatra. For some patients, it might be 4, 6, 10, but maybe get them to their best response and then think about a maintenance strategy with one of these other targeted agents we talked about.
And then I guess the question will be, then can you go back to the TDXD? And again, I think that will depend on how that progression happens and whether we can do that or not.
Absolutely. I think that whole line of thought only works if you can go back and you have the confidence that it's going to work as well later on. And so hopefully we'll have some real world data that comes out of all of this when we inherently do what we think is right to guide us in that. Because if that's not true, right, if we can't revisit it after a maintenance phase, then that changes the whole conversation.
Exactly.
So one of the things that struck me when I was looking at the data is, again, these are international trials, and a lot of times patients don't get to the post-progression therapy, which may not be a problem so much in the United States. I have to think that at least part of it is access to drugs.
Yep.
Do you all have any sense of whatever comes after TDXD, it works as good or not as good, or there's a shortened PFS, or it's just the disease? We don't have any sense that one drug should be the next drug based on any data that I'm aware of.
No, I don't think so.
Okay.
Yeah, I don't think so. So I would hope that most of our patients have access to ADCs after if you don't start.
In the U.S.
In the U.S., yeah. But I guess you're always taking that chance that like a patient could have very rapid progression and you don't get to that second line. But I think that's much more of an ex-U.S. phenomenon than we're going to see in our practice.
And are you thinking there is the possibility that if you went to maintenance, you could come back to TDXD, which you guys already talked about. But if you didn't do that, would you be doing HER2CLIMB or would you be doing something else?
Like TDM1?
Yeah.
I mean, again, I think it depends on the patient. And how they're progressing, CNS metastases, things like that. But I think it depends.
Yeah.
Yeah, and ease of administration. One's every 3 weeks. One's, a whole bunch of drugs, some oral, some IV.
Yes.
So all those things go into the mix.
Yes.
Well, I think we captured what I was hoping we would, and that is just to get your all impression of DB09 and sort of a historical perspective. Anything else you want to leave us with before we close this session?
I think we can just say that this is a good problem to have these options and to be so optimistic that we're afraid to do the wrong thing is, not really a place that I expected to be with these metastatic patients. And so there's a lot of hope here. And I think, just sharing that decision-making with our patients who are very, very savvy, understand this stuff, because they'll have thoughts. And I think we've got to respect that for the time being, especially when there's uncertainty of really what the best path forward is.
Yeah, I mean, I think it makes our job a little bit harder, but it's a good thing because we have these options that are producing better outcomes for our patients. And this really just brings us back to sort of the art of medicine. There may not be a specific algorithm that we have to follow, but we have to be doctors and have shared decision-making with our patients and just try to do the best that we can do.
Yeah, so I agree. I mean, taking the long view, we didn't have subsets of breast cancer when I started. So the fact that we have subsets of breast cancer, we have different ways we can approach each one. We didn't have shared decision-making when we started. So all of these things are an evolution that are going in the right direction, in my view. And the biggest challenge we have is how to deal with the riches of all these options and use them optimally.
Yep.
So with that said, I want to thank all of you for listening and you all for participating, and we hope to do it again sometime soon.